I would like to start this off by taking you all with me into the harsh reality. And to do this, I would like you all to imagine that you are in a country where you don't fully speak or understand the language. Also imagine that you are seeking help in the hospital. This time because the wounds you got from your abusive partner, they need professional medical attention. Then imagine that the interpreter that shows up, that is supposed to help you communicate what happened to the doctors, is a very close friend of your partner. This is quite an extreme case when it comes to using interpreters in healthcare, but it has happened in similar cases like this. And the problem with interpreters, it goes much further than this. For example, less than 5% of all interpreters working in healthcare in Sweden are certified for medical translations. And the Swedish regions and municipalities, they spend about 1 billion Swedish crown on interpretation every year. Most importantly is that all these troubles, they make it a lot harder to provide the correct care for the patient with serious consequences.
Okay, now it works. Okay, this is part of the problem that we are trying to solve. Yes. So when you go to the doctor, you expect that the conversation you have there will be private, right? Well, when an interpreter is involved, you don't always have such securities. We have cases in which interpreters over the phone have taken the calls in places such as the bus or at a party where everyone around them could listen in to the conversation. Or, as Alma mentioned, we could have a case where the interpreter is a friend of the family, for example. And in other situations, we can even have improvised interpreters, such as relatives to the patient or even a child. So this is why we want to use AI to preserve privacy in healthcare. We developed an app that enables secure conversation through real-time translation in an in-device manner. So this means that nothing leaves the phone or the room when you're using the app.
So the Mabel app, it works just like an interpreter in the sense that you speak to it in your language, it translates that and tells that to the other person in the conversation in their language. And it also, just like an interpreter, it doesn't require the internet to do this. This is very easy, it's great. And even more, there's one significant difference between an interpreter and this app, and it is that it's not only fully GDPR compliant, but it's also compliant with the Patient Safety Act. So our app, it works with fully voice-to-voice translation by utilizing natural language processes such as speech-to-text, translation models, and lastly also text-to-speech. And for that, to develop this, we of course need some data.
Yes, we need a lot of data. We need text and speech data. We need it to be preferably in the health domain and in several languages. So because our models are only going to be as good as the data we feed to them, we need it to be as representative as possible from our use cases. So fortunately, we have a lot of open source datasets to start with, but that data won't always cover all of our needs. So as much as we love the open source data, we need to be careful about it because there are going to be challenges involved in using them. So this is very important because there will be bias in this data, there will be faults, and if you don't do anything about it, the models will pick up on that. So one of the main challenges we found in this regard is about to collect and find data that represents our users. The first version of our app is targeted to the victims of the war in Ukraine. And while developing the Ukrainian version, we found that the majority of the open source datasets for voice data actually have voices mostly from young men. And who are the people, the refugees that are fleeing from the war? They are mostly women, children, and elderly people. So as you can see in the picture, about 60% of the refugees are women, and of these 40% of men, they are basically children and elderly people. Whereas in the datasets, the open source datasets, the 60% of men you see there, they are in their 20s, 30s, and 40s.
Yes. So as we said, open source data is not enough to avoid biases like this. So we need to collect data, and in our case, this means that we need to have data in our dataset that matches voices of the Ukrainian refugees regarding both age and gender. And at the same time that we want to collect data, we don't want to collect our users' data. That will be, I guess, perfect if we can use that, but we don't want your data because this is where we want to make a difference, where we have to make a difference. The AI that we use, it doesn't know about you and it will not learn about you. Your conversations and your data is truly private. There is no interpreter interfering, and there is no exploitation of your private conversations.
Yes.
So once we have the data representative of our probable users, we also have to deal with some issues regarding the translations.
Yes, and as you may remember from school, word-for-word translation is not always a good idea. And even if you manage to keep the sentence structure while translating from one language to another, this might not be enough as well. Because people have different ways to say things. Not only because they speak different languages, but also because they come from different cultures. They have different sayings and different ways to communicate. And this shows in several ways. One of these ways is in how people describe the way they feel, how they feel pain, for example, or another body sensation. So this description could be very objective, such as I feel anxious or I have a stabbing pain. But they could also be metaphorical, such as I feel like my heart is drowning or I feel like my heart is coming out through my mouth, which means that I have tachycardia or that I'm feeling very nervous. Or another one that you might have heard is I have butterflies in my stomach, which means I have anxiety.
I feel like all of these applied to me before we got up on stage here. But also in some languages, there are certain body parts, especially genitals, that are considered taboo to use or may sound offensive of the speakers of these languages. And they are also often replaced by other words or names for it. And this makes it even harder to find accurate translations for this that is socially accepted and that doesn't offend the users of our app, because that's the least we want, that our app will offend people, and especially in this sensitive matter as healthcare. And those of you who followed the snippa debate here in Sweden know that there can be confusion and issues about this, even if there is a word that is well known and well used.
Yes. So this means that we can't just take one data set, the same data set, and translate it to all the languages. We need the data to reflect all the ways in which the culture is represented in a language needs to be in our data as well, the data that we are using to train the models, so the models perform in the best way possible.
To get to a clean and good dataset is a tedious task, but we believe that this is a must to get a product that can perform equally well for all our users. So another thing that we have been looking at is to balance our data sets in the sense of having equal amount of sentences about women as of men. And this includes gender variations. And as you may know, languages are gendered to different degrees. And so this makes it a lot easier in some languages than others. I guess you can compare French to English and you get a hang of what I'm speaking about. Yep.
Yes. Yes, but the datasets were not the only challenge that we found while developing a voice-to-voice system. As you may know, healthcare facilities can be very busy and noisy places. So even if we have the best data, sometimes the models may still not be able to filter out the noise that come from the people walking around and talking, from the medical equipment that is beeping, the phones ringing, and so on. So how do we know how much noise is too much noise for the model to handle? Well, to have a better idea about that, we took a speech sample and we added noise to it in different levels. So the noise is of people walking down a hallway, and the levels of the noise are represented to the signal-to-noise ratio, or SNR. And this basically means the lower SNR means a higher level of noise. So let's take a look at that. I will play the samples for you. The first one is the lower SNR, so the most noise. Let's see if you can understand what it's saying there.
All of the agents were drinking, or in several cases, a mixed drink.
Anything?
That was hard.
Yes, that's very hard, a lot of noise. So let's try an SNR of -10 to see what we get.
All of the agents stayed for a drink of beer, or in several cases, a mixed drink.
Little bit better, right? A few words.
Yeah.
Let's see what we can do at -5.
All of the agents stayed for a drink of beer, or in several cases, a mixed drink.
It's starting getting clearer. Now 0.
All of the agents stayed for a drink of beer, or in several cases, a mixed drink.
Okay, so I think at this point we can pretty much understand what it's saying.
And 0 means that it's equal amount of noise and signal, right?
Yes,
Yep.
correct. But let's hear the 5 anyway.
All of the agents stayed for a drink of beer, or in several cases, a mixed drink.
Okay, so now we have the text that the model outputted. And we can see that at -20, the performance is pretty bad.
We don't know
Both-
if is this English?
Yeah, both for the model and for the humans, because it's very hard to understand. But at -5 and 0, we start getting to know more or less what it's saying and getting a more or less correct transcript. So now that we know what the noise makes to the sample, how are the possible solutions that we have for dealing with this? Well, we could generate some data with background noise in different levels and of different kinds, and then use this to fine-tune the automatic speech recognition models, or ASR models. And in this way, they could learn how to filter out the noise. This is good, but there's always be situations in real life in which the input is not going to be good enough, in which the noise would be too much for the model to filter out. So another solution would be to estimate the SNR to determine when an audio sample is not good enough to be transcribed. And in this way, when the SNR is too low, I could just throw a warning to my user saying something like, sorry, I didn't catch that, could you please repeat? And this approach has two main advantages. The first one being that I'm saving some processing that would be done otherwise. And the second, and the main one, is that I am avoiding to giving a transcript and making a translation that is incorrect for a patient and for a healthcare provider, such as a doctor, for example. And in this way, I am preventing miscommunication in a context so sensitive, such as the healthcare context.
That's great. Then we can have both an interpreter in the app and my old grandma asking me to repeat myself when she doesn't hear what I say. And with that, I want to wrap this up by saying that we have heard lots of concerns about AI lately. I think a lot of it nowadays about ChatGPT and its abilities and whatnot, but also how AI can be a threat to your privacy. And those concerns are, of course, both valid and relevant. But as we have shown here today, we also want to point out that AI can be a tool to better preserve privacy. By providing an alternative to human interpreters in healthcare, we can help to keep things private. We can help patients to get the care that they need without them having to expose their sensitive medical information. Thank you.
Thank you so much, Alma and Marina. This was truly fantastic, fantastic speech. Do we have questions from the audience? Unfortunately, we do. I wanted to ask all the questions. No, I need to be democratic, please.
Don't be that, please. It's okay. So, thank you very much. Have you tried this out in real life?
We have tried with not made up conversations as we have tried with a doctor and how the conversation would play out.
Not in real life?
Not yet.
Okay.
We're getting there.
One further question. Accents.
Accents, yes.
Yeah.
That's a huge thing.
Yes.
And that also has to be represented in the dataset.
Yes.
Yes.
This is another one of those features that need to be there for the model to learn. Yes. It's
Okay.
kind of part
Just
of the
one
culture.
comment about the dataset. Why can't you use or reuse text to speech to generate speech in that specific for your own datasets?
Well, I guess we could, but I'm not sure if the performance would be that good because I guess the features that the generated speech has is not the same as the speech we have in the normal environment.
Okay, just last question. Absolutely. Why do you want to replace a human for this translation? Why don't you support them instead in the beginning, the translators, by your system?
Well, of course we can do that, but as we said in the beginning, there are not that many interpreters working as just interpreters and very specialized towards this and working within healthcare. And yeah, it's because of this privacy threat that these interpreters may be friends and may speak about this in other settings than in the room with this doctor.
Yeah, they are not always trained,
No.
right, for keep the privacy and everything that a medical context would require, basically.
Thank you. I saw other hands raised. Yes, in the front.
Thank you. Are there other aspects of performance that you would consider for the app other than the technical ones? Like if you tested, what would you be looking for?
Of course, about how it's used, how the people, I don't really know what you're looking for here, but
Yeah.
how the people interpret the UI and how they use it and stuff like that, I guess.
Yeah, how they interact with the app, like the user interface, the quality of the translation, and not only, as we said, not only if it is correct, but is it capturing all the complexity that that exists in a language and the way we communicate. Yeah, and
Thank you. Yes.
Thank you very much for your presentation. I have one question regarding the unbalance of the data that you gathered or you collected. What are your different strategies to overcome that challenge? when it comes to gender, but also different accents, etc., etc.?
So this is open source data that we showed here. So basically the strategy is to go out there and collect data from the people that we need. So reach out to the organizations and places in which these refugees are and get data from them.
And one further question, sorry. I guess it's going to be, like audio recordings or something, but not particularly in the healthcare setting. It's probably going to be conversations, etc. Are you having also some ideas about how to overcome that specific problem?
Well, we need to have some representation of like medical vocabularies and such. So the idea that we try to achieve is to make sure that we have represented all these terms and things that would appear in a normal conversation, even if you're not taking data from the real, like medical consultations, for example.
Thank you.
Thank you. Are there any more questions? Yes, one in the back of the room.
Thank you. Building on the previous or earlier talk, have you considered using synthetic data? Because maybe not for every technical challenge that you have it can apply, but for example, with the signal to noise ratio and synthetically generating maybe different kind of roles there, maybe it can work somehow. So have you thought about it, or
Or synthesizing data? Or what was the question?
Yeah, using synthetic data for addressing some of these challenges at least.
Yes, of course, with the noise that is like adding synthetic noise to the data that we are doing. So yes, in that sense.
In a way, yes.
In a way, yeah.
Oh, yep. Thank you.
If there are no more questions, then I will thank Alma and Marina.